Hello everyone, my name is Ringler, and hope you're having a good day today. Hopefully you're not too saturated yet. There's a lot of information coming. And, you know, I've talked to some people, they've been here another years, and it's okay to come a couple times. You learn in layers, right? There's a lot of information. I'd like to start off by asking if anyone has specific questions. Anything that comes to mind? So, the purpose of the breakout sessions, I guess, is to tell you a little bit about ourselves. I'm a fertility specialist in Los Angeles with California Fertility Partners, who I've been practicing for 27 years now. And I've been helping gay men to build families for the past 20 years. And it's a fun process for myself, for our patients, and our nursing team, because the pregnancy rates are really high. Compared to infertility patients with all these obstacles. With egg donation and surrogacy for gay family building, we have the best possible elements and conditions for conception. We have a young egg donor who's carefully screened. IVF technology today provides great embryo culture conditions and embryo evaluation. And we're putting these high-quality embryos into the proven environment of the surrogate. So she's the optimal environment. She has no history of infertility. In fact, she has proven fertility. And so most patients get pregnant. Most patients get pregnant in the first egg donor cycle. Now, that first egg donor cycle should result in the generation of multiple embryos for multiple attempts at a pregnancy. 80 to 90% of the time, patients get pregnant from that first egg donor cycle. You don't have to do a second egg donor cycle. And so one of my jobs is to try to maximize your chance of success, try to optimize each variable. So in the talk this morning, I talked about egg donor selection. We want to maximize our chance of obtaining good eggs, good embryos, because if a cycle doesn't work, it's usually not the surrogate. It shouldn't be the surrogate. It's about the embryos. And our science of IVF has gotten so good today. We're really good at generating embryos. We're pretty good at grading and evaluating those embryos, but we still lack the ability to look at an embryo, to test the embryo, and tell with 100% certainty that embryo is going to make a baby. And that's why we don't have 100% success rates. We never will. It's human biology. We're trying to manipulate human biology to make this work, but human biology has all these links in the chain. If one little link that's suboptimal, it doesn't work. And that's a good thing for all of us, probably. So how do I maximize your chances? We start with the egg donor selection. Select carefully. I always prefer a repeat donor because I know how many eggs she produced previously, whether or not a pregnancy resulted from that cycle, and were there any warning signs. So I'll always ask the agency to give me the records of that prior cycle, because I'm going to look at the notes. We don't always get them, but notes. Oftentimes there's notes on the embryos, poor quality embryos, or funny-looking eggs. You know, that's all helpful information. Because ideally we want someone who makes good eggs, good embryos, pregnancy. Sperm quality. Everyone should start with a semen analysis. If you've never had one, do one this week. Because we want to know if we need to do any improvement. Things that can affect sperm production include anything that increases heat in the testicles, steam rooms, jacuzzis, spin classes, medications, testosterone, propecia, have to stop. They can affect sperm production. We want to optimize that sperm in preparation for the cycle. If the sperm is a little low, we'll use, there's multiple male fertility supplements that are available today, and they work. But to see any impact of that treatment, it can take 2 or 3 months just to improve the quality. If sperm is really low, we're going to use fresh sperm for the treatment cycle. For most patients, we can freeze sperm. Thawed frozen is just as good. If the sperm is really low, we want to use fresh, because sometimes when you freeze and thaw, men with very low sperm numbers who are thought to have no live sperm. So that's a potential disaster. For men with no live sperm in a fresh sample, we'll work with a urologist, and oftentimes they can do testicular aspiration on the day of the egg retrieval to obtain enough sperm to make it work. So, but we want to optimize the sperm in the process. Next variable is the surrogate. Surrogates are carefully screened. Most agencies will tell me that 90% of their applicants don't pass their screening. When they get to my patients, they match my patient with the surrogate. Before I see the surrogate in my office for a medical evaluation, I review all of her prior pregnancy records. We want to make sure, again, there's no warning signs. She needs the basic requirement for a surrogate that she has history of at least one normal pregnancy with delivery at term and no prior complicated pregnancy. If she delivered at 32 weeks or last pregnancy, no. So I'll review all those records before I see her to look for any problems. I see her in person, view her history, physical exam, uterine evaluation, infectious disease screening, urine drug screening to make sure she's going to be a good candidate. We want someone who's in good health, normal history, and a stable home environment. Pregnancy is complicated, it's difficult, so we want to make sure there's someone who's going to help her through the rough times. When you're talking with the surrogate agencies, you should tell them what your expectations are for the surrogacy process. Do you want to become very good friends with her? Do you want to go to her OB appointments? Or do you want her to do her job but be more distant? That should be really defined, and they will do that for the surrogate too. Some surrogates want to become best of friends with you in the process. Others, maybe they were a surrogate previously, they became really good friends with the last set of parents. They have their own family and kids, and they just don't have room for a new best friend, and that's okay too. So one of their jobs is to match expectations on both sides. So that's something for you to think about, what sort of relationship you want. You know, we're fortunate in California, we have wonderful surrogacy agencies. California has always been one of the most sought after places in the world for surrogacy because the laws here are very protective of your rights as the intended parents. Laws are very clearly established. Contracts are filed with the courts before delivery that define you or the two of you as a legal parent. And if you can be single male, gay couple, single woman, two women, it doesn't matter. The laws, the contracts define the legal parent, so no one has any claim to that child. But I've been practicing 27 years. I've never heard of a surrogate claiming to want the child. That's old TV movie stuff. So it doesn't happen today, especially with very reputable agencies like the CBS today. Monica Lopez is our head nurse at California Fertility Partners, and she does amazing work. And nursing staff helps me and my partner physicians manage all these cases. It takes a team of professionals to keep these cases running and running smoothly. There's a lot of details. We have 2 sperm providers. They each have FDA testing. We have an egg donor who has FDA testing. Surrogate and her husband has infectious disease screening. We have contracts with the egg donor, contracts with the surrogate. To keep these cases running smoothly, you need a well-oiled machine to keep track of all the details. And we've been doing this for the past 25 years, and we know how it works, and we know how to prevent problems. You prevent problems by being very meticulous, being very detailed, and keeping track of all these moving parts. I'm going to let Monica talk a little bit.
Hi, I'm Monica Lopez. I'm the nursing supervisor. I like to start with what makes California Fertility Partners unique. And Dr. Ringler does a great job with his patients. He's very accessible. He emails with patients all the time. If you require to speak to him briefly at the end of the day, he makes time, which is great in a physician. He also sees all the egg donors for all their appointments, surrogate for all their appointments, and the couples. So no, the patients are not seeing a nurse practitioner or ultrasound tech. Dr. Ringler sees all of his patients, which is also great. When our patients see Dr. Ringler for consultation, they are assigned a specific nurse coordinator. So that nurse coordinator will help you through the process. They'll assist you with what the next step is. They keep you well informed once the surrogate and the egg donor are seen. They provide you with calendars so that you are a part of the process and you're involved. We also just renovated our lab, so we have a new lab.
We have a beautiful new IVF lab. It's all state-of-the-art equipment. We have a new continuous culture system. We used to look at, well, 20 years ago, we looked at embryos every day. But we now know that embryos don't like to be disturbed. Any changes in light and pH can slow them down. So we look at the eggs the day after insemination, look for signs of fertilization. So it's a fertilized egg or one-cell embryo. We don't look at them now until day 5. Day 5, they're either a blastocyst or become a blast. Some will become blastocysts on day 5, some not until day 6, but they don't want to be disturbed when they're in culture. So we're seeing our new culture system, incredible blastocyst formation rate, and just better overall embryo quality pregnancy rates. PGS screening has evolved incredibly in the last 10 years. 10 years ago, we did it on day 3 embryos. Now everyone in the world does it on day 5, day 6 embryos because day 3 biopsy is harmful to embryos. Day 5 biopsy is not. PGS screening has been shown to significantly increase pregnancy rates and lower miscarriage rates in women over the age of 37. Donor egg population that hasn't been proven to do so. It should lower miscarriage rates. It does let you know gender. So if gender is important to you, that is the way to determine gender. If we have a large number of blastocysts, I had a patient recently had 18, 20 blastocysts, and they all look good. How do you select the best one to transfer? They did PGS, was very helpful, so I can immediately not consider transferring those embryos. So it can be beneficial if you have a large number of embryos. So we're very happy and proud.
How long can you store the fertilized embryos?
You don't have an expiration date. So 10, 20 years, they can expire.
And would it be with you, or would it be a rental? Like, would it go to long-term storage? Like how?
Well, currently we keep them all with us, and every year you'll be mailed a form what you want us to do with your embryos. Do you want us to keep them? Do you want to donate them to another couple? It's always incredible when patients donate them to another couple. We have many requests from patients who can't afford the process. And it's a beautiful gift to another individual.
Thank you.
What's the freezing process like for embryos?
The freezing is called vitrification. It's a rapid freeze mechanism. And we used to use what's called a slow freeze mechanism protocol up until about 5 years ago. Vitrification is less harmful to the embryo, and survival of freezing and thawing of a blast is about 95%. An embryo can be frozen and thawed multiple times.
So are you dipping them in like liquid nitrogen or something like that? But are you dipping embryos in like some really cold substance?
Eventually they're stored in liquid nitrogen. And we can take frozen embryos, biopsy them, refreeze them, and they do well. So most IVF cycles today are going towards freezing and thawing to a frozen embryo transfer. One of the big differences between babies born naturally and IVF for multiple studies over the years has been birth weight. IVF babies have been a little lower in birth weight. There have been interesting studies in the last couple of years showing that frozen embryo transfer birth weights are still similar to those natural. So suggesting that maybe the lower birth weights was related to putting the embryo back in that fresh, hormonally stimulated cycle. and that a more natural cycle transfer that we do with the frozen embryo transfer is better for the baby.
Also, does Truvada affect the sperm quality or sperm count in female?
No, some of the older medications do, but Truvada doesn't. Yeah.
Question on the PGD, the genetic diagnosis. Is it possible to find out likelihood of allergies? Because we've looked at lots of allergies. Don't want children to go through the same.
To find out at to decrease the incidence of allergies in the offspring. PGS is testing for abnormalities of chromosome number. So it tells us if the embryo has an extra chromosome or missing a chromosome. It's not testing for disease. PGD tests for if that embryo is affected by a disease. So if there's a marker for that disease that we can make a probe for, then we can test the embryo. But we couldn't test that embryo for allergies unless it's a specific genetic disease that has a marker, and then we could potentially test the embryo.